Welcome to Modern Management of the Older Adult, brought to you by the Institute of Clinical Excellence.
Hello and welcome to the Modern Management of the Older Adult podcast. My name is Dr. Samantha Chamberlain. I am a teaching assistant within the Older Adult Division of the Institute of Clinical Excellence. I'm excited to be here with you, continuing my task of working through this article that was put out by the John A. Hartford Foundation, Age Wave, and the Harris Poll. It's meeting the growing demands for age-friendly care with the additional, that's the study that was done. And then the actual article is the 5 forces disrupting or transforming healthcare today, with a added attention to the older adult population. So this is really focusing on this rapidly growing aging population that we have. We are on part 3, as I mentioned, and that is fragmentation, high cost, and inequity in healthcare. That's a big topic in and of itself, which is why this is broken up into 5 different episodes, because they broke it down into 5 different parts on that section. So just like the last 2 I've done, I'm going to read through it because there's just it's well written and it's such a valuable valuable topic to be working through, and all of it's just so important. So here we go. Fragmentation, high costs, and inequity in healthcare. Why does the nation that spends the most per capita on healthcare and leads the world in medical innovation fare so poorly in overall health? According to the Commonwealth Fund's Mirror Mirror report comparing the U.S. health system to 10 other high-income countries, the U.S. ranked last in 4 out of 5 categories: access to care, healthcare outcomes, administrative efficiency, and equity. The U.S. healthcare system is notably fragmented, costly, and inequitable, all of which compromise its ability to meet the healthcare needs of everyone, especially older adults. Again, we could go off on a whole tangent just about that little paragraph right there. Fragmented services and coverage. Fragmentation starts with providers. As people age and acquire additional chronic conditions, they often see multiple physicians and specialists and visit multiple facilities. This is one of those statistics I'm like, yep. So 30% of Medicare beneficiaries see 5 or more physicians annually. Providers may or may not be affiliated, and they often fail to coordinate regarding medications or treatment plans. If you've been around the older adult division for very long, you know that we collaborated on an article a couple years ago now, talking about how to make even PT less fragmented, from acute care to maybe skilled nursing to outpatient to the fitness. We did a whole article and developed this sheet that would help, that you can just kind of a pass-off sheet. So of course this gets our wheels thinking of how can we do this with a more patient-focused, patient-facing system to where they can advocate for themselves a little bit better. Moving on. Providers may or may not be affiliated, and they often fail to coordinate regarding medications or treatment plans. Only half of our survey respondents ages 65 and older say their primary care doctor coordinates with their other providers. So care coordination falls to the individual, and that becomes more complicated with age. A little bit of assumption there, but it can be more complicated. To throw in an additional statistic added here is 5 or more physicians annually for 30%. Another 22% see 3 to 4. So over 50% of people ages 65 and older are seeing at least 3 providers that may or may not be communicating with each other. That's a big problem. That's where this fragmentation is coming from, is while it's great to have people that are specialized in certain things, it can also be a little bit detrimental in some ways, because we don't have one general centralized location that's kind of sifting through all of this. They just send it out and to some degree assume it's taken care of at that point. They've done their part, they've sent it to a specialist, but not everyone is checking back in to follow up with what that specialist said, if it's in line with the rest of their healthcare, if it's in line with the other ailments that they may or may not have, if it's in line with what they value and what is important to them as an individual. So lots of reasons fragmentation are happening here. Not great outlook as far as that becoming less the case, unless we start advocating for our patients to have a better system in communicating to their physicians, or ways for physicians to listen better to their patients. Moving on. Fragmentation and complexity are also driven by the country's public-private healthcare payment systems. For those over age 65, there's Medicare with its 4 parts, often coupled with private Medicare Advantage insurance paid for individually or perhaps subsidized by an employer. For some individuals, Medicaid can cover additional services, and that varies by state. Just more complications here. The innumerable coverages and options form a Byzantine maze that most people struggle to understand and navigate. As a healthcare provider, I don't understand half of it. I get so frustrated, and I unfortunately say insurance is dumb on the daily. And I just mean that from a accepting, billing, there's so many different parts to it, and every insurance is different, and it's such a challenge to navigate all of it. And that's coming from a healthcare provider. So imagine someone who doesn't have any information on how any of that works and is just trying to feel better. It's such a challenge. Needed care often falls through the cracks, and unnecessary and duplicated care often occurs far too frequently. Side quote here they have, the U.S. does not have a healthcare system. If you've been around ICE very long, you know that we say that there's a sick care system, and these people seem to agree. It's really lack of a system. It's so disjointed and uncoordinated. That was from Brandon Wilson. He's a co-interim president and CEO of Senior Director of Health Innovation, Public Health and Equity Community Catalyst. So we're not the only ones that believe that the U.S. does not have a healthcare system. They lack a system. We call it a sick care system. Either way, it's not working. High cost and unaffordability is the next part here. Americans spend a lot on health privately as well as publicly. Situations vary widely, but the average person over age 65 with Medicare coverage spends over $6,600 out of pocket for health services, medications, and supplemental insurance annually. And those in poor health spend an average of 20% of their income on health care. That does not include long-term care costs, which Medicare generally doesn't cover, which average $104,000 annually in care facilities and $69,000 in home. Add it all up, and the average couple will spend $472,000 on out-of-pocket health and long-term care expenses throughout retirement. $472,000 on out-of-pocket health. So the long-term care expenses range from $89,000 with healthcare expenses averaging $383,000. So that's where they broke that up. So long-term expenses and then general healthcare expenses come up to that $100,000. Insane. Okay. Due to the complexity of the payer system, Americans frequently face unexpected costs and unwelcome surprises. Insurers limit care to save money and often to increase their profit. People with fixed incomes and limited financial resources can struggle to afford health insurance premiums, and they most often postpone or forego prescriptions or care because of costs. These short-term cost-based choices lead to worsening health and higher healthcare costs in the long term for far too many. There's several examples of this that we could use. The insurers limiting care is, of course, a big soapbox for all of us as far as if they would pay for gym memberships, if they would pay for preventative care at a higher level, preventative PT, prehab, those kind of things, it would shorten their long-term cost. But they don't want that upfront cost. I'm sure there's a lot more that goes into it, but to me, it just doesn't make sense all around. I have an example of this recently. I stepped on something, I jumped out of my truck. It went through my foot, basically attached my shoe to my foot, couldn't take my shoe off. Luckily, I had a friend nearby that is a paramedic, and he helped remove said item, but then, of course, I needed a tetanus shot and antibiotics because, yuck. But I was left, urgent cares. It was late enough in the evening that most of the urgent cares were closed. I could have went to the ER. I didn't want to worry about my foot. There were so many things going into it, but, the first thing I said is I don't want to pay ER prices for something that's not an emergency, but I knew I needed to get one. And he advised me, he's I would go get it tonight. I did my own little Google research and also had my kids with me. So I was this can wait till tomorrow. I pulled into the hospital and I was between the cost and just handling the kids and handling this, I went home because overall it was going to be fine. There wasn't an emergency situation, but still the cost came to mind, and not wanting to spend that much on healthcare and postponing it because of cost definitely came to mind. So imagine this on a larger, longer term scale. I have so many patients, I see a large Medicare population that come in and say they waited to get treated for something until they were on Medicare. They postponed treatment even though they'd been dealing with it for a decade because they knew it would be paid for later. Well, now it's so much worse and recovery so much longer, whereas they could have been feeling better and enjoying the last decade instead of kind of suffering through it or, managing through it. They could have been thriving, thriving versus surviving. Like, they've been surviving through it, and all because of the costs that were going to be associated with seeking care. There's also widespread inequity. Fragmentation and costs compound the fundamental inequities in healthcare access and outcomes. Those who can navigate the system and afford to pay can receive excellent care. Sometimes, right? If you are in the right place. But too many people are underserved based on financial status, gender, race, and ethnicity, and sexual orientation, disability, location, and age. Inequity is evidenced in the outcomes of lifespan and health span. We talked about health span in part 2. That's another really upcoming idea to go along with longevity. It's not just about living long, it's about living long in a healthy way with limited chronic disease, limited impairments, those types of things. So lifespan and health span vary significantly by race. Black Americans and Native Americans both have health spans below 60 years. 60 is not old to me. I see this all the time. I work within Cherokee Nation. I don't work for Cherokee Nation anymore, but I work in on the Cherokee reservation. It's considered Cherokee land, tribal land. So I've always been surrounded by this population, and yeah, most of my people have some sort of chronic disease well before 60. The average life expectancy by U.S. Census District ranges from living into one's mid-50s to one's mid-90s. That is a big difference. 50s to 90s. That average life expectancy varies that much just by where you live. Men in the top 1% of household income live 15 years longer than those in the bottom 1%. 15 years longer. Another side quote here. Age-friendly care focused on what matters to older adults can help us achieve health equity for all. That's by Peter Mate, President and CEO of the Institute of Healthcare Improvement. So big difference in lifespans based on ethnicity. So, for example, Asian descent total lifespan is 84.6, 84 and a half. Health span is 77.5, so about a 7-year difference there. Whereas African, Indian, or Alaskan Native, the total lifespan is average of 68 with a health span of 53. So a 14-year difference as far as health span goes. So almost double just based on that. Caucasian kind of falls right in the middle. Inequity is also apparent in healthcare processes. Older adults living in rural areas have less access to health and long-term care support. Think of transportation, availability of doctors, long-term care availability. All of these things are very limited in the rural area that I'm in as well. LGBTQ older adults are more likely to be denied care or provided inferior care. Black and Hispanic Americans are less likely to receive an accurate or timely diagnosis of dementia. I think they were assuming knowledge abilities, and knowledge level, as well as literacy levels. Women suffering from heart attacks are less likely to be diagnosed and treated than men. Older adults experience high rates of care-related harm, treatment delay, and discoordination of efforts. About 1 in 4 Medicare patients admitted to a hospital experiences patient harm during their stay, such as medication-induced delirium, pressure injuries, and infections. Older adults are also more likely to have their concerns dismissed and their conditions unnoticed. And they receive less attention in medical research and representation in clinical trials. Thank you to Dr. Christina Previtt for making this less, at least pushing the needle towards getting some older adult research in there. These systemic inequities are often compounded as when racism and ageism overlap. Those who need the most care can often receive the least. Those who need the most care often receive the least. To address these issues, fragmented services can be bridged with more advanced and interconnected information systems for individuals, building on patient portals, and for institutions, better coordinating providers and payers. Costs can be driven down through direct government action and accelerating the transition from fee-for-service to value-based care. Inequity can be reduced through increased investment in the social detriments of health and lifelong health care access. Another side quote, if you take everything that's wrong with healthcare, you can put a little exponential sign next to it when it comes to aging, particularly the fragmentation of care. That's from Vivian Lee, a doctor and author of The Long Fix. So what you can take away from this is obviously our system is very broken and needs a lot of help. And I'm hoping that with articles like this and with more people advocating for better healthcare system and more people getting more and more frustrated with insurances and the control that they've somehow managed to get a grasp on over the last few decades, hopefully enough people are recognizing that that's not working, that we can start to make a difference in the way that care is handled and the way it's paid for, all of these things that are just really broken. But what you can do, kind of your call to action, things you can take away from this podcast, are listen to your older adults. So don't be the norm. Don't be their usual care. Be the person that hears what they're saying to you, listen well, make a plan based on the information that they are providing to you, not on what you've assumed, right? You can't make good decisions on bad data, as our CEO, Dr. Jeff Moore, likes to put it. It's a great way to keep your mind focused on the words coming out of their mouth instead of on making sure you get your documentation done, right? Know the resources in your area. I'm not just talking about where you can send them off to, but maybe have a list that you can just hand to patients or highlight what they're asking for. This can be transportation availability, home services, hospice care, even just contact the local hospice places in your area, because they also usually have a really good grasp on the resources that are available to older adults, to those that need health care services. Call your local area on agency. Look this up if you've not heard of a local area on agency. I hadn't until I started working with ICE and didn't think I had one. I looked it up. It's more of a multi-county. It's not just local to one city because we are so rural, but there is one, and I was able to call them the other day and help coordinate some transportation for someone that had to travel outside our area but still needed frequent transportation. So those are great people to contact. Think about your telehealth. Look at technology classes. So some individuals are able to navigate technology, some are not, but our local VOTEC has classes for older adults or for anyone that is interested in learning better how to use their technology. So that's something look at your VOTECs, look at your senior centers, look at these places. Or if you have someone that is a former computer teacher, or you have some retired individuals that were in tech or technology or anything like that, see if they'd be interested in hosting a class, helping so that people can access care easier when they can't get transportation. See if they can turn some of those appointments into a telehealth appointment and feel confident that they can get logged on, that they can navigate the system correctly to be able to attend those appointments that way. And then another really big one is check the medication list. So, we usually ask for this on intake paperwork, or people forgot it and, try to tell them to bring it next time. There's an app called Inequity. We don't have any affiliation with them. I'm sure there's multiple ones. This is just the one that I've used. And you can put in their entire med list, and it will tell what interactions may be going on. You can catch a lot of stuff this way. This is kind of where you're bringing that fragmented care kind of back into one place, one centralized place. And you can, I've color-coded a list for people before and said, hey, will you please take this to your primary care provider or your pharmacist and have them do a medicine reconciliation, because some of these medicines may not be in your best interest anymore. Like one doctor they had moved, so a doctor had put them on several medications, another doctor had put them on other ones, and even though it went through the pharmacist list that's similar to this app, it didn't get caught, and he was having tremors, he was having a lot of forgetfulness. There was lots of stuff going on for this gentleman that I'm thinking of specifically, and I highlighted that list, and he took it to his doctor, and his doctor called the pharmacist and was like, hey, I need you to better check my patient's medications that you're filling. And so it created this big conversation between multiple providers and really created that interdisciplinary approach that we're hoping for and trying to reduce that fragmentation. So don't discredit how much value you bring to just listening to your patients, looking over that medication list that you're probably already gathering anyway, and really paying attention to those details and what your patient is telling you, what providers they're seeing, what specialists they're seeing, and kind of bringing it all together, even if it's just providing some patient education to them in a little bit slower manner as opposed to the 5 to 10, maybe 15 minutes they get with some of these specialists. just hearing them and answering their questions can be really powerful, really helpful. And you can do this while they're moving their bodies. You can do this, like, if they need more of that, just having a conversation. Just set aside some time for some of these individuals that aren't getting the care that they need. All right, that's part 3 of this. We got 2 more parts. They're all just as exciting, and I'm super pumped to work through them. The next one is going to be part 4, healthcare workforce shortages. We all know about that, and it just got worse 2020 through 2023. I think it's kind of like settled in a little bit, but there's still a lot of shorthanded places in a lot of fields, but especially healthcare. Awesome. If you are enjoying our content, please check out Older Adult Level 1 with the Institute of Clinical Excellence. It starts May 19th through July 13th. We just started this cohort of L1, so it's a good 8 weeks before we start again. L2 starts May 15th and it runs through July 9th. So if you've taken L1, please jump in and join us in May for Level 2 of Older Adult. And then, of course, you can catch us live April 5th in Longmont, Colorado, or Pinellas Park. I don't know where that's at. There wasn't a state. So Pinellas Park, I forgot to look that up. So if you're in one of those 2 places, join us in a couple weeks or a week and a half-ish. April 12th, we'll be in Madison, Wisconsin. And then we have a little bit of a stretch. So if you don't catch us in the first couple weeks of April, there's Easter, there's Sampler, there's Mother's Day, there's Memorial Day. So we got kind of a long stretch of not being out on the road there. And then May 31st, we'll be in Greenville, South Carolina. So it's kind of a rundown of our next few live courses. Like I said, if you don't catch us the first couple of weeks of April, there's a little bit of a hiatus for some holidays and Sampler and, all the fun things that come into the spring. And then end of May, we're back out on the road pretty regularly in Greenville, South Carolina. Hope you enjoyed it and looking forward to see you.
Thank you for listening to the MMOA podcast. If you found this helpful, please share with someone that could benefit. And if you're looking for more practical content to help you better serve older adults, head over to www.mmoa.online, where you can learn more about our free resources, our community, continuing education courses, and our certification. Once again, that's www.mmoa.online. Thanks for listening.